I want to welcome Dr. Grant Baldwin. He is the Director of the Division of Overdose Prevention at CDC's National Center for Injury Prevention and Control. He leads the division that monitors trends in the drug overdose epidemic and other emerging drug threats. Before that, he was the Director of the Division of Unintentional Injury Prevention for 11 years, and he's been at the CDC for 20 years. He received his public health training at the University of Michigan and Emory University. And I've asked him to come talk about his role at the CDC and the CDC's role in monitoring and trying to help mitigate the overdose drug epidemic in the US. It's 12:15 Eastern time. We have him for an hour, so I'll turn it over to Dr. Baldwin.
Great, thanks so much, Chris. It's really an honor and privilege for me to be with all of you. As Chris mentioned, I think I'm going to focus my remarks this afternoon on the changing drug overdose epidemic and our response to it. I'm going to talk for about 20 minutes. Actually, Chris and I talked about this being a good way of handling things. I'll talk first about the burden, how the trends have changed over time, and frankly, how we got to this moment. Then I'll take some questions. Then I'll walk through key aspects of our prevention and response portfolio. And I'll close with some areas that CDC is interested in right now. Again, that second piece should take about 15 or 20 minutes. So we use the balance of time for questions. Of course, feel free to ask your questions in the chat. Chris, as you probably know, is monitoring this, and hopefully I'll address them as things go along or as once we hit those breakpoints. So, drug overdose deaths have never been higher. To put a number on it, we've lost over 840,000 of our fellow Americans since 1999. This includes over 70,000 in 2019 alone, or about 193 people a day. This is a time series map that shows county level drug overdose mortality rates shifting between 2003 and 2008, and the growing abundance of red, of course, showing an epidemic that continues to worsen. Every state has seen dramatic increases in their mortality rates. And unfortunately, the maps are only current through 2018. The 2019 map is not currently available, and we can talk a little bit later about data timeliness. So in those 70,000 deaths, we know that over 70% are opioid related, and now over 70% of those involve synthetic opioids other than methadone. As you heard from other speakers in this great series, this is largely illicitly manufactured fentanyl or IMF. When we think about the opioid epidemic, of course, you need to think about it in these three overlapping and reinforcing ways, beginning in 1999 with the prescription opioid epidemic, a surge in heroin-related deaths in 2010, and finally, skyrocketing of deaths from fentanyl and fentanyl analogs beginning in 2013, and that skyrocketing continues to this day. Fentanyl, 50 to 100 times more potent than morphine, and some of those analogs like carfentanil, 10,000 times more potent. All told, over 495,000 Americans have died from opioid overdoses since 1999. And opioids are now nested in a broadening polydrug crisis driven by stimulants like cocaine and methamphetamines. From 2013 to 2019, the cocaine-involved death rate increased threefold, and the death rate from psychostimulants with abuse potential has increased fourfold. Approximately 32,000 Americans died from an overdose that involved cocaine or a psychostimulant in 2019, about 16,000 each. And opioids were involved in 70% of cocaine-involved deaths and 50% of psychostimulant-involved deaths. This data looks a little bit more holistically at all drugs involved in overdose deaths in the first 6 months of 2018 for 25 states that are reporting to CDC as part of our state unintentional drug overdose reporting system, or SUDRs. I'll talk a little bit in the response portion of my remarks about SUDRs. A note in this graphic that 2/3 of all opioid deaths, again highlighted here by the arrow, involve fentanyl. Also, 1/3 of deaths just involve fentanyl with no other illicit opioids on board, meaning that fentanyl alone is now a problem, something that we haven't recently experienced. And finally, just 17% of opioid deaths were prescription opioid related alone, and prescription opioid deaths are declining. That's a success story that I'll talk about a little bit later. Deaths from fentanyl analogs at this moment in time are also declining. That's the good news. Of course, the bad news being that improvements are being far outpaced by fentanyl. In the same study of 2018 data, we reported that 63% of all opioid deaths involve some combination of cocaine, benzodiazepines like Valium, Xanax, and Ativan, or methamphetamine. Specifically, 34% involved cocaine, 33% involved benzodiazepines, and 12% involved meth. A more recent study using suitors showed that illicitly manufactured fentanyl, heroin, cocaine, or methamphetamine alone or in combination were involved in 84% of overdose deaths from January to June of 2019. The 10 most frequently occurring opioid and stimulant combinations are shown on the slide, and they accounted for 77% of overdose deaths. 6 drug combinations, including the 3 most common, involved IMF, and IMF and no other opioid or stimulant constituted 19.8% of deaths, IMF and cocaine 10.5%, and IMF and heroin 10.3%, as you see on the green bars. This study, I think, and this is going to be another important point for conversation, this study also looked at the circumstances of each death and found that there was at least one potential missed opportunity for intervention that was identified in 63% of overdose deaths, so something like a bystander being present. This is a figure from an MMWR from this February, where we characterized, as we do every year, summarizing the drug overdose data, in this case, the 2019 data, looking at trends, and it looks specifically at the role of synthetic opioids other than methadone, again, largely IMFs. Between 2013 and 2019, the overdose death rates for synthetic opioid co-involvement, this is the graph on the left here, increased 6-fold for prescription opioids, 27-fold for heroin, 32-fold for cocaine, and 18-fold for psychostimulants with abuse potential. And in the absence of synthetic opioid co-involvement during the same period, death rates increased 3-fold for psychostimulants and just slightly for cocaine, 1.5 to 1.7 per 100,000. However, rates decreased for prescription opioids and for heroin-involved deaths. In short, we have an independently growing meth problem on top of an opioid crisis that's now being driven by IMF. At the outset of this epidemic, the most impacted persons were white, rural, and men between the ages of 25 and 54. But now I like to characterize it as an everybody problem. So from 2015 to 2018, the opioid overdose death rates increased among both sexes, persons aged greater than 25 years old, all races and ethnicities, and all levels of urbanization. And in this time period, death rates increased among males 47%, blacks 25%, persons aged 35 to 44, 51%, and in large fringe metro and in large central metro areas, around 50%. Again, an urban problem as well as a rural problem. To put these data in context, this is something I often like to do. There are almost 50,000 Americans that died of an opioid overdose in 2019. That's almost double the number in 2013, so just 7 years ago or 8 years ago, and nearly 6 times the number of deaths in 2010. And because of the COVID-19 pandemic, it looks like 2020 will be even worse. In fact, a lot worse. We released a HAN, or a health action alert, last December, and in it we looked specifically at the provisional estimates in overdose deaths for the 12 months ending between June of 2019 to the 12 months ending in May of 2020. And as Chris mentioned, we released just this Wednesday morning new provisional estimates that update these data that suggest that upwards of 90,000 people have died in the 12 months ending in September 2020. Again, continuing to reveal a concerning acceleration of overdose deaths during the pandemic. There are many potential reasons for this. I suspect other speakers have spoken about some of this, including persons struggling to maintain access to essential harm reduction treatment and recovery support services, initiating or increasing substance use to cope with the stressors and social isolation created by the pandemic, and then using illicit drugs alone more frequently. Again, another context setting number, we lost 375,000 Americans to the COVID-19 pandemic just in 2020. I just pulled the MMWR this morning to look at that. And that is the trend. If the trends through September of 2020 continue through the end of the year, we might lose closer to 100,000 people to a drug overdose in 2020. So stand by for that. I think all of us who do this work on the everyday are eager to see those trend lines change. So again, those preliminary estimates are just through September of 2020. So these maps show the percentage change in the 12-month provisional count of all fatal overdoses on the left, and just fatal overdoses involving synthetic opioids on the right. I didn't have a chance to update these data. Actually, I asked my staff yesterday if they could do that, and they haven't gotten back to me yet. Drug overdose deaths during this time increased more than 20% in 25 states and DC, and 10 to 19% in 11 more states and New York City. Of the 38 jurisdictions with available synthetic opioid data, and we can talk about data availability later as well, 37 jurisdictions reported increases in synthetic opioid overdose deaths, including 8 reporting increases greater than 50% and 11 reporting increases between 25 and 49%. So historically, deaths involving IMF have been concentrated in the 28 states east of the Mississippi, where the heroin market has been primarily dominated by white powder heroin. And as you can see on the map on the right, the IMF market is expanding westward, frankly, as we worried it might. And I can talk later about the meth market expanding eastward. So the next few slides pull from the National Survey on Drug Use and Health, or NSDUH. Again, maybe other speakers have pulled from NSDUH. This is an annual household survey that provides up-to-date information on drug use in the United States. It surveys non-institutionalized US citizens 12 and older. And in 2019, the survey included 67,000 participants. This graph shows the relationship between lifetime use of a substance and the number of other substances used. The point for this slide, I'm attempting to drive home the point that the more widely used a drug over the course of a lifetime, the higher the percentage of users who do not use other drugs, as well as, frankly, the flip. The less widely used, the more likely the drug is used with other drugs. Also, less frequently consumed substances are rarely the first use and often added later in a person's substance use trajectory. Heroin is the best case in point, with only 2% of Americans reporting lifetime use, and these users reporting an average of 6.5 other substances that they used. This graph shows the current past year use and past year initiates to select illicit drugs. On the left, 1 in 5 people aged 12 and older used illicit drugs in 2019, with marijuana use far outpacing other drugs. This is up almost 20%. It's a 20% increase in past year use, or 9.5 million more users just since 2015. The number of new initiates of substances declined in many categories in 2019, and the increase in both past year use and trends in new initiates is driven, again, largely by the cannabis market. So in short, increases in overdose deaths that I talked about are occurring against a backdrop of overall stable or declining rates of illicit drug use other than cannabis, underscoring that's really the illicit drug supply that is a key driver of the current overdose crisis. I also wanted to talk about how polysubstance patterns have changed over time. So researchers looked at past month co-use of prescription and illicit opioids in 12 non-opioid psychoactive drug classes. This is from a national sample of about 15,000 persons entering treatment for opioid use disorder. So past month illicit opioid use increased from about 45% in 2011 to 70% in 2018. And at the same time, the use of prescription opioids remained high, but decreased slightly from 95 to 85%. Use of prescription opioids alone dropped from 55% to 30%. As you see on the graph, past month use of at least one non-opioid drug occurred in nearly all participants, greater than 90%, with significant increases in methamphetamines. The authors of this paper conclude that polysubstance use is ubiquitous among those with an opioid use disorder, but also that there's been significant changes in polysubstance use patterns over time. The nature of polysubstance use is also worth noting. So it's not just simply that you're co-using, it is co-use where use of multiple substances are meeting criteria for having a use disorder. This is data from a nationally representative sample retrospective cohort study of veterans diagnosed with an opioid use disorder receiving care within the VA system. So 41% had an opioid use disorder only, or OUD. 23% had OUD plus one other substance use disorder, and 36% had an OUD and 2 other substance use disorders. So common comorbid SUDs include alcohol use disorder at 41%, cocaine or stimulant use disorder at 30%, and cannabis use disorder at 22%. So again, the majority of veterans diagnosed with an OUD appear to have at least one comorbid substance use disorder, and many have multiple substance use disorders, again, underscoring the need to refine, as I'm sure you've heard from other speakers, our treatment approaches. So in summary, polysubstance use is not new and is common among persons who are struggling with use disorder. The patterns of substance use are changing, and some polysubstance use is occurring without a user's knowledge, specifically in the case of cocaine, methamphetamines, and some other drugs. The proliferation of synthetic drugs, especially IMF, greatly elevates the overdose risk of polysubstance use. That's something that I think is driving the current trends. And persons struggling with multiple substance use disorders face greater challenges accessing treatment and recovery services. As I mentioned in my first couple of slides, and I think I just have a couple more data slides and then I'll take a break for questions, we are making some progress. After steadily increasing beginning in the late 90s, prescription opioid use in MME, or morphine milligram equivalents per capita, peaked in 2011 and has decreased by over 50% through 2019, with the greatest reduction in prescribing being among persons receiving a high daily dose or greater than 90 morphine milligram equivalents. This is a threshold value in the CDC opioid prescribing guidelines where primary care clinicians are noted to have caution. Prescription opioid use in MME per capita is expected to decrease to a level last seen in the year 2000 by the end of 2020. This was data that I pulled at the end of last year. I did want to mention, though, that county level prescription opioid dispensing still varies sixfold across the United States in 2019, with 5% of counties dispensing enough opioids for every person to have a prescription. And opioid prescribing still continues to vary across specialties, with primary care physicians, physician assistants, and nurse practitioners accounting for over 55% of scripts. And finally, there is noteworthy variation in indication-specific prescribing, with significant differences in prescribing rates, days supply, and daily doses across indications, and frankly, a non-alignment of these practices with existing evidence-based guidelines, including those by professional organizations and others that are central to a clinician's specialty of choice. Fatal overdoses and opioid use disorder cost the US a little over $1 trillion in 2017 alone. This is the most complete accounting to date of America's opioid crisis in a study that was recently released. Costs for spending on healthcare, opioid use disorder treatment, criminal justice, and lost work productivity, as well as estimates of cost for lost quality of life and lives lost, were computed in this study. And key findings you see in the graphics here. So the value of life lost due to an overdose was $480 billion. Opioid use disorder accounted for $471 billion in costs. Healthcare costs, $31 billion. Opioid use disorder treatment, $3.5 billion. Criminal justice spending, $14.8 billion. And put this in context, it's estimated there's slightly more than 330 million people living in the United States. That means that each one of us is getting a bill annually for $3,625. And the epidemic, the impact of the opiate epidemic is so pronounced. I think you probably know it's impacting and altering US life expectancy, something I expect to continue. This is data showing a decrease for 3 consecutive years from 2015 to 2017. This is the first time this happened in over 100 years. The last time was when we last experienced a pandemic, the 1918 flu pandemic. This graph shows the relative contributions of the 14 leading causes of death and how long Americans might live. It shows that the declines has affected nearly all races, both sexes, with decreases due to unintentional poisonings for non-Hispanic white and Black men, and women for that matter, driving these trends. And while it's not shown on the graph, it is deaths in persons 15 to 44 years old that's really pulling down overall life expectancy. And again, when life expectancy charts are updated, obviously 2020, the life expectancy is going to go down, both because of the drug crisis as well as the pandemic. So this is my last data slide. I wanted to sort of summarize how we got to this moment. I have listed 7 factors on this slide. I think the first few are well known to you. It's the last 3 which are driving the current trend. So pain being designated the 5th vital sign in a campaign that was pressed for by the pharma-backed American Pain Society. Beginning in 1999, the 5th vital sign moniker was adopted by the VA and ultimately the very influential Joint Commission. And the Joint Commission accredits hospitals and health systems, and it was widely adopted. Second, there was an underappreciation of the addictive potential of prescription opioids. There was at the time, a very limited literature with very serious methodological flaws that mischaracterized the risk of addiction at less than 1% in chronic opioid users. And the literature was featured and touted by pharma and others despite its methodological flaws. Third, there was very aggressive marketing of these drugs to clinicians. Purdue Pharma, the maker of OxyContin, spent over $200 million on marketing in 2001 alone. They doubled their sales force and paid over $40 million in bonuses to that sales force in that year alone. And at its peak, Purdue made almost $3 billion on OxyContin in 2013. And since the late 90s, they've made over $36 billion. Fourth, there's these rogue actions by clinicians who ran pill mills for profit. Again, pill mills are typically cash-only operations where nefarious doctors prescribe at will with limited physical examinations. There's very well-published press reports about some of these activities. And the last 3, as I mentioned, are really associated with illicit opioids and are really, frankly, supply issues. More people are, as I mentioned a few minutes ago, are not really using, it's really the drugs that are driving the supply that's driving. So sophisticated actions by drug traffickers that made it easy to open new heroin markets, smartphones being a key part of that. Sam Quinones' book Dreamland talked about it being just as easy to order heroin as it is to get a pizza. The perfect and destructive storm that is illicitly manufactured fentanyl make it highly sought after by users because of its potency, and it's easier and less costly to make and distribute and sell by drug traffickers, all the while generating astronomical profits. I think I saw in Chris's note to me that you had a chance to connect with Bryce Pardo, who is a really fabulous report on the future of fentanyl, where he documents that fentanyl is 1/100th, so a penny on the dollar, the cost of heroin. So drug traffickers, if you're interested in making lots of money, you can make a lot of money, and it's easy to make and traffic. And then finally, the mixing or co-use of fentanyl and its analogs with other drugs like cocaine and meth, which I shared with you earlier. The westward expansion of fentanyl and the eastward expansion of meth, which is also driven by changes in the narconomics of meth and the production, which I don't have a tremendous amount of personal expertise in, but I know it's a key driver of the crisis. So let me stop there. It seems like a natural pause point, and see what questions you have of me. So I'm looking at the chat now.
So we had a question from Christine, and then Barbara, and then Kyle.
Yeah, I just wanted to know, with the decrease in prescription opioid use, how do you account for the possibility that some of those, I guess, people who might have been misusing prescription opioids didn't shift to using other drugs like heroin or fentanyl? Is there even a way to account for it? And like, can you be sure that that's actually good news if they might be driven to more deadly alternatives? Because
yeah, so one of the things that, I'll talk in a few minutes about the 2016 opioid prescribing guidelines. And one of the things that we are concerned about is the misapplication of those guidelines. So I want to say, and it's, this is not going to be a surprise to you, Kristen, that we have a lot of interest in people who are in pain getting treatment and effective treatment. We think the evidence supports that opioids may not be the best course for that. And so there have been documented instances of people being abruptly tapered or quote unquote fired from their clinicians. And so I think the evidence suggests that opioids, that some patients may do well long-term on opioid therapy, but the lion's share of the scientific literature says that when you look at pain, function, quality of life, and other outcomes, that that may not be the case. So what we at CDC are interested in is If not opioids, what, and how do we get payers and others to support reimbursement for those services and other efficacious non-opioid pharmacologic or non-pharmacologic treatment modalities. And so I think the upcoming 2022 opioid prescribing guideline will attend to some of that.
Okay, Barbara?
Hi there, Barbara Morris from the NBC station in Providence, Rhode Island. I was looking at your map and I believe you showed Rhode Island as having under 10% increase in overdose deaths, and it just came out this week that we had 25% increase in overdose. So I was wondering, how often do you update that map, and was that in 2020?
So it depends. I think it was, if the map that you were looking at was the map from the HAN, that was updated through data through May of 2020. The provisional estimates are updated monthly around, frankly, this time of the month. So you can look there. I'm happy when we get to the end of the conversation to post the link to the provisional estimates number, where you can look both at the overall number and then specific states by drug class. Again, those are provisional estimates, but that's something, to be honest with you, Barbara, that we collectively have a lot of pressure on to get more timely data about the changing drug crisis, both to inform programmatic activity. So what do we do about it on the ground in places like Rhode Island, but also, what do we do at the national level to sort of pivot our public health approach? So that's something that we are thinking about and worrying about and wanting to do better about. I can talk a little bit later about some other programmatic work that we have better situational awareness on the ground in states, but something we're working on. I will also say that one of the things that has changed because of CDC support and other investments is that drug specificity. So back when I started in this job many years ago, we could only usually report out on quote unquote drug overdose deaths writ large, because the variability across states and jurisdictions that reported had great detail on drugs on board at the time of death. That's changing over time. It's gone from in the mid 70% to 95% in recent years. So we can make an apples to apples comparison across states. So that's changed. So, but if Barbara, part of what you're asking is around timeliness of data, that's an area that we can and should be doing better in.
And just real quick, because you kind of brought up, we're getting a groundswell of emails from people who are saying they're not getting the opioids they need. They're in pain because doctors are hesitant to write prescriptions for them. So what do you say to people who say they absolutely need this, but their doctor won't write these prescriptions, and that they're living in pain?
It's tough. That's a tough question. Obviously, as I said to Christine, obviously everybody deserves effective pain treatment. That's an individualized conversation. I'm not trying to evade the question between a patient and their doctor. I think there's growing evidence that other treatment modalities can be just as efficacious, the sort of NSAIDs in particular. Some of it has to do with the dose duration that you're initially started on and how you're potentially titrated up. I will say that, again, I think are there patients who do well long-term on chronic opioid therapy? Yes. But the preponderance of the evidence is continuing to show that the risks outweigh the benefits. But that risk-benefit analysis really needs to be a conversation between a clinician and a patient.
Okay, so we'll go to Kyle, then Georgia, then Andrea, and then go back to the presentation.
Great.
Thanks for making time for us today, sir. Really appreciate it. I'm with Gray Television's DC Bureau. Curious, when it comes to steps the CDC can take, I think many of us can see the natural nexus between what the CDC did with prescription guidelines and trying to tackle the problems with use of, or misuse, I should say, of prescription drugs. What, if any, policies do you see you folks moving forward with in an effort to deal with these illicit substances that don't obviously go through a doctor's office? And how much are you looking to pilot programs in states to take your cues and see what's effective?
Yeah, so thanks for the question, Kyle. So in a second, I'll talk a little bit about, maybe actually a lot about what we're doing with strengthening partnerships between public health and public safety. A colleague of mine has been at the forefront of leading that. So I'll talk about the overdose response strategy, which is about building a bridge between sort of what the an intelligence officer and the drug community, the law enforcement community knows, and what the public health community can do, and how you build a bridge between those, and what are some of the approaches that we can use, evidence-based approaches, which I'll talk about in the second half of the presentation. So Kyle, if I don't fully answer your question, just ping me again at the end, and I will do a better job.
Okay, Georgia.
Hi, thank you so much for your time. I'm wondering, and maybe I'm just a negative person, but I see like, drug overdoses at an all-time high, and yes, there's reasons for that, like fentanyl and the pandemic and everything, but how on earth can this ever be reversed? Or can it be reversed? I don't know.
Yeah, I mean, I think, Georgia, we have to do better. I think part of the challenge is the drugs involved are changing, and the lethality and the potency of drugs, and the polysubstance use patterns are a real problem. I, on most days, try to maintain some degree of optimism. I feel like we just have to get better control of synthetic drugs, specifically in this case fentanyl right now, but also some of the narco-economics around meth. And once we manage that, and manage across basically all the continuums that I'm about to talk about in the public health response, I think we can make a difference. I think it's going to be a long haul, and some of it also involves really attending to broader things, more upstream things. I think I have in some of my backup slides some of the work we're doing around adverse childhood experiences and some of the other structural issues that predispose people for misuse and abuse, and sort of continue the cycle of substance use. That's another avenue. But again, this is, if this was an easy problem to solve, we would have solved it. And the problem is that the goalposts keep moving in the case the drugs involved are changing, and therefore, we need to constantly be pushing ourselves to stay out front and attentive to the changing landscape.
Thank you.
Okay, and Andrea.
Yeah, hi, sorry about that. I'm wondering what is known so far about the impact on the sort of next gen of users, particularly of cocaine and methamphetamine, drugs that people have tended to dabble with in their youth, now that oftentimes those are also drugs that contain some fentanyl.
Yeah, I mean, I think that's an area we need to study further. So I think there are non-CDC sort of anthropological work that's done that can sort of characterize the marketplace, but we're also trying, whether it's reaching out through harm reduction or some of our other community-based partners, or I'll talk a little bit later in my presentation about CDC is now administering the Drug-Free Communities program, which is the 730 plus coalitions that we fund to do youth substance use prevention and to stop youth from initiating. I think that's a portal into connecting to new users and understanding where they are and why they're using and their concerns, et cetera. We're also trying to be more attentive, and I'll talk at the end about our RX awareness campaign that started with a prescription focus, given the title, but we're now looking to sort of move into the illicit space. And another issue that we really haven't attended to well yet from the CDC perspectives is the issue around stigma, both stigma of individuals, families, and communities, which is a focal point of my division's work at CDC.
Thank you.
Let's go to Kathy for one final question, then the next break, and then we'll move on. Great.
Thank you so much for your time. I was just going over my notes, and I don't know if this came up, but I kind of want to piggyback off Georgia's question. We had a speaker on Wednesday who was talking about, how Oxy was never approved in France, but because our healthcare system is sort of for profit, and the people who are on these various boards then they joined Purdue, and then Dr. Taylor was even talking about some policies like harm reduction policies, which we don't implement in our country. It just doesn't feel like the will at the top is there for rewarding people who are approving drugs that are medications that clearly are just bad, and other countries aren't doing that. I think Helena Hansen referred to, she used France as an example, like they never,
Portugal, yeah.
was it Portugal? Okay. Never approved OxyContin in their country because it wasn't, for whatever reason. I guess I'm just curious. It feels like at the end of the day, there's no desire to create harm reduction policies like an injection site, or to allow, we allow people to make money off of these drugs that end up harming a lot of people and creating a market that is lucrative and hard to stop. So I'm just wondering what your thoughts are on that. Thank you.
Yeah, thanks. All for tough questions, right? I think what I would say is that I think we can continue to push on the harm reduction. We need to push on all fronts, but on the harm reduction lane, and specifically something that's happened recently that I'm personally very, very buoyed about is just in the last few weeks, we now have the ability to purchase fentanyl test strips, which are the sort of, like litmus test-like strips that allow you to test your drug supply. That's another thing that we can put in our armamentarium to sort of help users understand what's in their supply. Because as I said, and as you all know, part of the challenge with where we are with the crisis now is that some people are actively seeking out fentanyl, but many aren't. And so we need other harm reduction strategies like the use of fentanyl test strips. Safe injection sites is another new opportunity. I think you will see we're evidence-based at CDC, and we'll push things where the evidence supports as the evidence base around safe injection sites and other harm reduction strategies continues to get strengthened. I think we'll take on those challenges. But the last thing I'd say, Kathy, is that I'm very interested in learning from what other developed countries are doing that we can learn from, and how we can work with our DEA colleagues and others to influence, the supply in this country. That's a whole separate conversation. I suspect you're having it with other experts in the field, but we should be learning from what other developed countries are doing, and where the political will exists here, take advantage of that. So again, probably not as hard hitting of an answer as you wanted, but certainly that's from the seat I occupy. That's my perspective.
I appreciate it. Thank you.
Okay, well, let's let you get back to the presentation, and then we'll have some time at the end for some more questions.
Great. So this is the HHS 5-point strategy to combat the crisis. It was launched in 2017. At the time, we're really focused on making things better prevention, treatment, and recovery services to prevent the health and social and economic consequences associated with misuse and abuse long-term, better data to improve the timeliness and specificity of data, something I just talked about, but I think we need to do better to inform real-time public health response as the epidemic is evolving. Something several of you just asked me about, better pain management to enable access to high quality evidence-based pain care that reduces the burden for pain for individuals while also reducing inappropriate use of opioids, better targeting of overdose reversal drugs to ensure broad provision of these drugs to people likely to experience or to respond to an overdose with, again, focus on reaching high-risk populations such as justice involved as a specific example, so Naloxone, and then better research. By the way, I'm sure you all saw the Biden administration priorities that cut across the government that are beyond the HHS priorities about expanding access to evidence-based treatment, advancing racial equity issues in the approaches to drug policy, evidence-based harm reduction efforts, enhancing those, supporting evidence-based prevention with a focus on youth substance use, reducing the supply of illicit opioids, advancing recovery-ready workplaces, again, something we at CDC and our sister agency, the National Institute for Occupational Safety and Health, are working very hard on with some of our partners, and then expanding access to recovery support services. This is a slide I got from former CDC Director Tom Frieden that I love. It's an approach to think about how we should sort of manage our prevention and response work. So we need to think about two groups of people with two very, very different sets of needs. First, we need to obviously address people who are already dependent on prescription opioids or heroin or fentanyl or other illicit substances here, improving access to medications for opioid use disorder and other treatment modalities, wraparound services critical as well, expanding access to and training for administering naloxone, including those who are not knowingly using opioids, their friends and family and others who are likely to witness or experience or respond to an overdose. But second, we need to stop people from becoming dependent on these drugs to begin with. Again, continuing to address opioid prescribing, while down, is still problematic, and it's continuing to fuel some of the epidemic. But now with IMF and other illicit opioids, it really does require enhanced collaboration between public health, public safety, community partners, and others. This is a slide I put together just within the last week or so. It puts a finer point on 4 of them. So expanding provision and use of naloxone and overdose prevention education. These are some actions that we defined within the PON. Again, expanding locations where these services are offered and locate them whenever possible to include things like primary care settings, retail pharmacies, support groups, outpatient SUD treatment programs, mobile outreach, basically anywhere and everywhere that people who use drugs might be, to be expansive. Expand access to and provision of treatment for substance use disorder. So additional efforts should be made to train clinicians. This is something that when clinicians I speak with that are my age, that were trained, they didn't nearly receive enough training on treating individuals with use disorder. So supporting MOUD treatment and efforts to reduce stigma, encourage clinicians to become Data 2000 waived, and to prescribe medications for opioid use disorder up to their patient limit. So methadone, buprenorphine, naltrexone, et cetera. Intervene early with individuals at high risk. This is an area that I think we should be talking more about. So those historically underserved, persons experiencing homelessness, persons transitioning from institutional settings back into the community, such as from the criminal justice system, and those with a previous non-fatal overdose. So the people who are at greatest risk of dying from an overdose have certain characteristics that we should be attending to. And finally, improving our ability to detect overdose outbreaks due to fentanyl and other novel psychoactive substances. I can talk at the end, I think it's in some of my backup slides, about some of the work that a sister center at CDC is working on. I'm going to run through these because I know no one likes to see sort of strategic planning slides, but I think they're relevant here, at least the next couple. I will mention just simply our 3 overarching goals. They're not sort of smart, objective-y kind of goals, but they're kind of get you out of bed in the morning kind of goals to help reduce opioid overdoses right now, urgency of the now, given the nature of the fentanyl crisis, to address emerging drug trends, methamphetamines, cocaine, and obviously we're living in a US right now with a greater efforts around legalization of cannabis, and what does that mean for use trajectories, and of course to preventing youth initiation and use. I'm going to skip over I'm going to be talking at some length about each of these specific strategies with specific examples of investments we're making right now, but this is the lens with which we make investments. I did want to mention some of our guiding principles, and I put them as sort of context setting for the work we do. This is kind of like the watermark, or our operating system, if you will, of how we, when we make decisions about what we're doing and how we do that work, we want to keep these principles in mind. There are 9 of them, and you see a few of them listed on this slide and the remaining on the next. So a substance use, and some of these may be like, well, that's self-evident, Grant, but in some instances, that's actually not been the case. Otherwise, we wouldn't have to have them. So a substance use disorder is a chronic relapsing brain disease and not a moral failing. It's really physiologic changes in the body, as you've heard from others like Dr. Compton from NIDA, that are driving decision-making and use. That context counts. That substance use is influenced and reinforced by past and present life experiences and circumstances. And so our prevention, treatment, and recovery activities need to attend to those life course and contextual factors. We're data-driven, so data need to be the bedrock of our decision-making and action. And I'll talk about our large-scale cooperative agreement that has that as its cornerstone. That prevention, evidence-based programs work. We need to invest in them to a greater extent. That recovery, long-term recovery, is possible. And we, within CDC, think that the public health and public safety can be a bridge and a linkage safety net to more comprehensive treatment and recovery support services that others within the federal landscape help support, such as SAMHSA. This is a sort of fundamental belief, and I can talk more in the Q&A about how this was added, but we need a system of care and supports that protects everyone at every turn. I have a fundamental belief that overdoses should never happen if that system is optimized, that sort of broad system, and I'll talk about what that looks like. We need to lift each other up and end stigma for individuals, families, and communities. So not just individuals struggling with a use disorder, but families and caregivers who support them. And the last two, really focusing in on issues of disparities and social determinants of health that have impacted historically underserved and or vulnerable populations, such as those I mentioned earlier. Again, achieving the highest level of equity for all. This is our largest investment at CDC. This is a $300 million program for 3 years. We're funding 66 jurisdictions. They're all part of our overdose data to action program, so 47 states and 16 big cities. It integrates every portion of our state-based funding into one announcement, and it has this fundamental premise, basically using more timely, comprehensive, localized, integrated, and actionable data to catalyze prevention and response activities. So basically, what is happening in a state or a locality, and how does that inform activities on the ground? So it includes a breadth and depth of things on the prevention side, everything from prescription drug monitoring programs to connecting state health department work to local health department activities, linkage to care, which is relatively new in this cooperative agreement, health system and provider supports, public safety partnerships, and others. States and jurisdictions receive anywhere between $2.3 and $7.5 million in funds, and we just entered year 2 of this program. As I said, data guide what we do on the scope, scale, complexity, and urgency of what we're trying to achieve is bigger and bolder than ever, and so we need a surveillance program that can meet that need. And so we have 2 programs which I'll talk about. First, DOSE, and then SUITRS. DOSE is the drug overdose surveillance and epi system. We fund jurisdictions anywhere from $90,000 to $300,000, and we want them reporting data through the National Syndromic Surveillance Program, which captures data anywhere between 24 and 48 hours after an ED visit. So really incentivizing faster reporting. Now have a coverage of 75% of emergency departments. States are now required to report on 4 specific indicators. We're sort of changing the number of indicators that states report out on. And that's changed over time. This is SUITRS. This is the state unintentional drug overdose reporting system, now covers all drug overdoses. So states must report 75% of drug overdose deaths, or in big states like California, greater than 1,500 of their unintentional or undetermined deaths. We're also supporting medical examiners and coroners to enhance the toxicological testing for all the drugs that are on board, and incentivizing states to report data even earlier than the provisional estimates that are currently reported through NCHS. I'm going to speed up a little bit because I want to make sure there's time. I'm realizing now that it's already 1:05, and I want to use some time for questions at the end.
Just Dr. Baldwin, they'll have full access to the PowerPoint, so they can look at it
great.
later.
Yeah. So we're also investing in innovative surveillance work, so I wanted to call that to your attention. I think I'll skip over some of the slides on the prescription, the update to CDC's opioid prescribing guideline. This is the March in 2016. We're really focused on the translation of that guideline, and we're in the process of updating it to look at the following 4 areas on this to expand the scope of that guideline. This is the overdose response strategy. This is the connecting a drug intelligence officer and a public health analyst in, right now it's in 30 states and across the country, and 21 or 22 HIDAs. We're looking to go nationwide with this later this year. This is, I think, a big focal point to Kyle's question earlier about really needing to, what do we do differently now in public health, given the changing nature of the epidemic. We are trying to push out, as I mentioned, some of the evidence-based programming. So we are collating when we can, what does the evidence say, and how do we get that into practitioners in the field. And so this is the purple book that a colleague of mine put together. We're in the process of updating that. We're also investing, and this is, that same colleague has this mantra of, and I love this moniker of adoption acceleration. So how do you get good ideas brought to scale. And so this is a program that has a terrible acronym, but it's a fantastic program. It's the COOCLI program. It's called Combating Opioid Overdoses Through Community Level Intervention. This is making seed investments in novel strategies across the country. And you see a few of them listed on the slide. Once you review the PowerPoint, I'm happy to make some connections to some of these COOCLIs. It's absolutely fabulous. Let me mention real quickly, this is another area that I have a great degree of interest in. You're familiar, I'm sure, with overdose or with fatality reviews. There are also overdose fatality reviews. This kind of kicks it up to the next level. This is where you have everyone and anyone who has anything to do with people who may encounter somebody who has a substance use disorder to come together to both analyze specific individual deaths, but then look systematically and holistically about what they could be doing differently and come up with a performance management based system or approach to improving it. It's sort of riffing off of what was the RxStat program in New York City. I have a tremendous amount of energy about this program. This is the FAST program. And then I think this is one of my last substantive slides. This is the Opioid Rapid Response Program. So it was designed to attend to the negative impacts for potential populations impacted by the closure of a pill mill. So when DEA or others take an action against a nefarious prescriber, you're potentially leaving obviously a large patient population without access to their prescription opioids. And as was asked of me earlier, so what happens then? And so we want to be attentive to that and bridge people into supportive services, connect them to other responsible clinicians and or treatment and recovery services. And so that's what ORRP is all about. I mentioned the RX awareness campaign. This is real stories of real people and what they're doing. I've talked already about the DFC program. Let me leave you with this slide, and this may be a fodder for the questions that in our remaining time together. So these are some of the things that we're thinking about right now. I deliberately used Post-it notes when I created this because there are ideas we're sort of working on right now at CDC. So how do we increase support for local communities? How do we strengthen overdose outreach using peer recovery coaches and patient navigators? How do we strengthen linkage to and retention in care? So again, that cascade of care that we've seen work so effectively in HIV. I talked about the Adoption Acceleration Project and expanding ORS and the CDC opioid prescribing guidelines. What are some of the other novel approaches to surveilling the issue? So everything from social media, what can be gained from that to inform some of our efforts, increasing education around and training to decrease stigma among clinicians themselves about treating individuals who are struggling with use disorder. I just talked about FAST, addressing, right now we've heavily focused on opioids for reasons that make sense, but we're expanding our work into stimulants and other polysubstance use. I talked about ACEs and some of that work. Yeah, so let me stop there. I know we only have 10 minutes left or 7 minutes left, but I'd love to hear more questions, please.
Okay, so if you could stop screen share, and then we will go to Christine, Madeline, Barbara, and I think I saw, and Georgia, and then Kyle. So we'll get as many in as we can. We can spill over a few minutes past 1:15 if you're able to.
Let me just look at my calendar. I think I can. I just need to look.
Okay.
Yes, I can spill over a little bit as well.
Okay, go to, Christine first.
Just quick question about, you say unintentional poisonings. Do you distinguish that from, I don't know if there was a suicide that involved illicit substances, does that get removed, or does it all kind of get lumped in together if the death involved illicit substances?
So if the death was a drug overdose death, it could be coded as an intentional overdose. So a suicide death would be coded as an intentional overdose. And so it's not, what I'm largely reporting out on is unintentional drug overdose deaths.
Thank you.
Madeline.
Hi, I'm Madeline Beck. I'm with the Mountain West News Bureau, so reporting for NPR stations in the Intermountain West. I was wondering, you said that there's going to be enhanced state requirements as far as reporting. I know that, and I've seen the map from a couple other presenters where it shows that several states, you can't see that certain synthetic opioid use because they just don't report that. With these new reporting requirements, are we going to start seeing that in those new states?
Yeah, so I think we're making more and more progress. So I think the short answer is yes. We've made, if you look even just a few years ago at some of our summary reports, the number of states that we used to say, how is the synthetic opioid problem changing, was dramatically lower than it is now. And that's what some of CDC's investments have helped to support. So a greater number of states and localities reporting greater amounts of drug specificity and drugs involved in those overdose deaths. So it's been a long process, and frankly, been really personally buoyed by the investments in data modernization. Unfortunately, the COVID-19 pandemic has also shed light on some of the challenges with our data systems. And so this is just another area that we're continuing to make investments on. And frankly, it's, Madeline, a business individual who's a partner of ours in some way and runs an organization called Shatterproof, you may speak with Gary Mandel, said, you would never run a business on data that's 2 years old. And so we really need very, very specific, very timely information. And so we're really pressing ourselves to meet the moment.
Right. And so just to reiterate, those specific new requirements, will they make sure that all states are then reporting synthetic opioids, or is that going to be a state-by-state decision?
Sorry, Madeline, it's a state-by-state decision. We are looking to incentivize as best we can using every tool that we have available to us at the federal government. But if I go back and looked at the OD2A map, some states chose not to apply for our funds, which we were very, very disappointed about, given the nature of the crisis.
Thank you.
All right, next, Barbara.
Yeah, I don't know how it is in many states. In Rhode Island, you can get Naloxone without a prescription. There's a standing prescription. We also have community organizations passing out Naloxone on the streets, wherever it's needed. So I guess my question is, should you also include the fentanyl test strips? And then I also understand they're limited too, because it will tell you that there's fentanyl in the drug, but it won't tell you how much fentanyl.
Yeah, so there are obviously limitations. I think Rhode Island is a great case example because of, it's there's a lot of people in Rhode Island, but it's relatively small state, and you've got in my judgment, these are my words, not anyone else's words, a very progressive system in place, and that's very attentive to the needs of people who use drugs and how to respond to the crisis in a very, very coordinated, sort of task force driven way, where even at the governor level or previous governor levels, really bringing people together that have equities. So I think there are gaps and limitations to every strategy that we have available to us, but I'm the kind of person who believes that we need to be doing everything possible. And while fentanyl test strips do have their shortcomings, and for example, if there are some of the fentanyl analogs that are on board, you may not, it's not meant to be a safe, no safe, but it gives users just an additional piece of information, or frankly, public health and public safety who can be using these strips to test confiscated narcotics on what's in the supply as well. This is all about sort of increasing situational awareness about what's happening.
And just real quickly, we do have a coordinated effort. I think we're doing a great job. Yet our overdose deaths are up by 25%. So it's mind-boggling, as much as we're doing in this state, that our death rates from overdose remain high and are going up.
Yeah, I think that's the scourge of fentanyl and the analogs and its contamination in other drug supplies. And maybe this is Georgia's question earlier, where this is kind of take the winds out of your sails kind of stuff, because a lot of people are working really, really hard to do this work, but it's really we really need to figure out ways that we can tackle supply related issues as well. But the other thing that Bryce probably mentioned, which I thought was a really great insight from his report, he wrote about, which was striking to me, about and this was the question earlier around sort of other markets, but there's evidence to suggest that once fentanyl is in an illicit market, it's really tough to get it out of that market. So you need to really invest in all these other strategies. So we can't rely on interdiction to reduce supply. We really need to increase we need a whole system approach.
So we'll have Georgia, Kyle, and then Adriana, and then that'll be it.
Thank you. I just had a question. Do you have any idea how fentanyl strips are received elsewhere in the country? I'm from the Detroit Free Press, and they're really not popular here. I mean, people have a hard time giving them away, to be honest.
They're not popular among users, or they're not popular among elected officials?
They're not popular among users.
Okay. Yeah, I mean, I think there is regional variation. I'm a Michigander, so you know, it's probably not surprising for me to hear that, but yeah, I think that some of that is around education we need to do about their utility, and you know, so I think more to come on that. So I think there is regional variation, but at the federal level, in fact, we're working on guidance that's attentive to the new guidance within our OD2A program, our Overdose Data Action Program, to our recipients to, you know, outline when, how they should be using fentanyl test strips and to inform their work.
So are people outside of Michigan using them with success? I mean, users using them, or do you not know yet?
I mean, I think the scientific literature suggests that they do have efficacy, but I think it's variable, and I would have to follow up with you after. If Chris wants to send me a note, I can, you know, connect with some of my staff to get you a more cogent answer.
That'd be great. Thank you very much.
Okay, Kyle.
Thanks again, Doctor. Curious how the CDC is evaluating some of the emergency pandemic rules and waivers that were put in place to deal with those getting medication-assisted treatment. Specifically, some speakers have mentioned the ability to get a telehealth prescription for methadone and be able to take home a multi-day supply instead of having to show up on a daily basis and wait in line, et cetera. And whether the CDC might then look at that in order to suggest whether Congress might want to consider changing those laws, other rules and regs.
Yeah, so CDC is being consulted. There are larger HHS efforts afoot to look at, you know, sort of what have been some of the pandemic-centered accommodations to meet people where they are, and sort of with telehealth. I think I was on a panel in the last 2 weeks where, you know, some of these accommodations work well for some users, and they're not working well for others. So we need to sort of figure that out. But my instinct is that we will see, I think, not just within issues around treating substance use disorder, but more broadly. Obviously, we've all been accustomed to now telehealth and its role in our general treatment and well-being. So I would anticipate, you know, I would hope that we would look critically about what's working in that space and make changes to federal rule that would allow that. I mean, again, this is really not CDC's jurisdiction. So, you know, take my comments, Kyle, with a grain of salt.
Appreciate it.
And finally, Adriana.
Hi, my question. So the other day we had a speaker who was saying how, you know, we treat addiction like it's a disease and we should continue doing that, but we also need to consider the social factors as well. So I'm curious, because I was looking at the last slide that you had there about how the CDC can, you know, approach this, their goals going forward. How can they start using social factors as well? You know, like what things would they take into account to try to create a path forward, essentially?
Yeah, so we are taking a very holistic approach and looking at social determinants of health and trying to and encouraging our recipients to make investments on those sort of broader structural factors that may create and reinforce ultimately misuse and abuse and the cycles of use patterns that I mentioned earlier. The challenge for us, Adriana, is that some of those are long game strategies, and we have, as I mentioned in our strategic planning, we have an urgency of the moment, you know, and we're on the cusp of potentially losing 90,000+, close to 100,000 people. We need to, I'm a kind of both and kind of person, so we need to attend to those structural and social determinant factors while we also come up with, okay, what can we do right now that doesn't have that many of our fellow Americans dying? I wish I had a better answer for you. I just think we need to attend to both, like things like the best example that we're investing in very intentionally at CDC right now is in the area of adverse childhood experiences. There's growing evidence. I didn't have a chance. It's in the backup slides of some of our investments in the Martinsburg Initiative in West Virginia. They're very striking. Some other evidence-based programs through another terrible acronym, our IOPSL program we're investing in right now that are ACE-centric. I think that's the best example of where we're trying to get upstream on some of the structural systemic issues. But, you know, we could always be doing better.
You don't sound very proud of CDC's acronym selection committee. You should.
No, I like to be a little bit playful, Chris, on some of these things, just because, you know, you say them and you're like, how did you? Because, you know, some of these should be clever, like remedy, or, you know, but, you know, IOPSL and Kukli doesn't exactly roll off the tongue. So I like to you know, be a little tongue in cheek with them. They're fabulous programs. They really are.
All right. Okay, so Dr. Baldwin, I thank you very much for the time and the presentation packed with data. Thanks for sticking a few extra minutes to get these final questions in. So thank you very much. And Dr. Baldwin, I want to thank you again. And that's it for today. Thanks much, guys.